Thank you, Ranking Member Murray. I appreciate the members of the panel coming together to inform us on this most critical issue for the American family. I very much sympathize with the comments made by Senator Baldwin. Prescription drugs, I think, is an area of important focus for this committee, and an area where an opportunity is apparent for us to help the American consumer. One of the things that Senator Braun and I have worked on as a measure to help in this regard is to assure that individuals who are responsible for co-insurance for the prescription of for prescription drugs, the co-insurance rate is determined based upon the net price, not the retail price of the drug, so that when rebates or the like have been provided, that the consumer has the advantage of that feature, and hope that becomes part of the final bill. But most of the discussion today has focused on different points of view with regards to surprise billing, and so I want to, for a moment, focus in that area. Mr. Kavanaugh, you indicated that one of the challenges with benchmarking is that you have a huge network of people that are responsible for setting Medicare rates, but that something of that nature doesn't exist if we were to put in place a benchmark system. On the other hand, Ms. Mitchell indicated that she would set the benchmark based upon the Medicare rates. So would that not remove the complication that you're concerned about, which is to simply set a benchmark rate and do it based upon either 1.25 times the Medicare rate or 1.5 times or equal to, but basically use that as the benchmark figure? Would that remove that complexity you were concerned about?
Sure. Thank you, Senator. The only point I was trying to make is in Medicare Advantage, there is a benchmark rate that operates this way, but it's publicly known. Like, I can go online and tell you today what the benchmark rate is in every community for every service. This legislation, one of the options, would create a new benchmark rate with a different methodology, and someone's going to have to go and build that and figure out what those rates are. I didn't mean to make any bigger point than that. Yeah, thank you. So, Ms. Mitchell, do you have any comment on that?
Again, we think that this is the most straightforward, efficient, and transparent way to come up with fair rates, and the evidence supports the rate.
Would anyone want to comment on the advantage or disadvantage of using that system, which is using, if you're going to use a benchmark, using the Medicare benchmark and keying off of that as opposed to an arbitration process? I'm concerned just at the first blush that with an arbitration process, it's going to be highly complex with after the facts negotiations going on and differences in different communities and arbitrators that may or may not be familiar with the specific circumstances. Would it just be a lot easier just to tie into the Medicare rate one way or the other? But if people have different views, Mr. Nichols, please.
Thank you, Senator. Yeah, I would have a different view. So I think our concern is, first of all, it's well documented, and Congress's own advisory board, MedPAC, says that Medicare does not pay the costs for hospitals that are fair. And to base anything on Medicare rates, I think, is a mistake. Secondly, there's no difference between that and Medicare for All, which was just described earlier, which we have real concerns about. And the third thing I would say is one of our concerns about setting a rate is if it's out there, what we want is for negotiation to occur between providers and insurers. If there's a default rate, why won't the insurer just always go to the default rate? There won't be a negotiation. They won't have broad networks, which they need. And again, I think we're coming back to the same thing as Medicare for All.
I'd like to follow up, if I can, Senator.
Please.
To be clear, again, when we are going through an arbitration process, we're using a benchmark. You got to decide who wins and who loses, and so ultimately we're doing the same thing. And so I would push back and simply say that if you think Medicare is too low, and that's completely fine with me, then it doesn't mean you can't use Medicare, at least in concept. You could say Medicare, heck, Medicare times 2, Medicare times 3, you know, whatever number you think is appropriate. And so the one advantage that has is it isolates it from being gamed by the market actors, that is, trying to engage in these kind of shenanigans to be in or out of network to affect the benchmark rate that's a function of that. So that's the one advantage.
Ms. Mitchell?
Thank you. I concur. I would also point out that actually 25% of U.S. hospitals manage their cost well enough that they are successful under Medicare rates. And we're not talking yet about costs. The recent report by RAND shows that hospitals bill commercial payers and employers an average of 240% of Medicare. So what is the actual cost to provide that care, and how do we agree on a common standard? We believe that 125% is fair.
Thank you very much, Mr. Chairman.